Postural ratio assessment using sonographic and strength characteristics of the rectus abdominis and erector spinae. If we look at the role of the entire lumbopelvic hip complex in our postural control, core stability, and overall injury prevention, especially when we think about low back pain, especially chronic low back pain episodes, strength and size assessment of those muscles is very prevalent in the literature. And a lot of times we do move beyond those spinal stabilizers and start with our superficial muscles that are our quote-unquote major contributors. And a lot of times we think of those when we think about the exercises within our core exercises, not necessarily our stability exercises, but with our crunches and any sort of rotational crunch exercises. We think about our obliques, our rectus abdominis, and then on the posterior side, our erector spinae. Specifically for this project, we're going to focus in on the rectus abdominis and our lumbar erector spinae. Thinking about that anterior versus posterior, I want to flip it and think of what is the ratio of our anterior to posterior contribution. And if we look at the people sitting in these all too common postures, we have an interplay of our anterior and posterior muscles constantly, especially in the work environment, whether you're sitting up forward in your desk, leaning over onto the desk towards your computer, up in your chair, or you're slumped down backward into your chair. We have this ratio back and forth that there may be a loss of strength, there may be weakness, and there may just be overall dysfunction that we need to assess fully, and that comes into play with our postural ratio. And we can do this pretty well with our clinical assessment, and we have a few different modes that we're able to do that. And when we look at these muscles within our lumbopelvic hip complex, ultrasound is a really nice way to do that. And another thing to consider is that an increase in muscle thickness may not always mean an increase in strength. We have to think about whether the contraction that we're measuring is concentric or eccentric in nature, and whether we're asking the individual that we're assessing to do a task where we would expect an increase in strength. We've seen in other studies where peak torque and quadriceps cross-sectional area relationships are stronger in a patellofemoral pain group. And we really want to bring all of this back to clinical accessibility. So really looking at, we could use something as simple as a handheld dynamometer, which is also pictured on screen, and our ultrasound measures to merge very clinically accessible tools and look to see how they are related to one another. I think it's really important to start to put these answers together. So the purpose of the study was to determine postural ratio differences of the trunk between thickness changes of rectus abdominis and erector spinae and strength output using a handheld dynamometer in physically active individuals. When our participants first arrived in the lab, they had B-mode images captured of their rectus abdominis and erector spinae at rest, and then we started the strength assessments. So they had flexion and extension measurements taken, and they had B-mode images captured during both of those positions. Their handheld dynamometer measurements were captured at the same time. We had MVICs taken of those same positions. So during max trunk flexion and extension, they had 5-second holds. They were given verbal encouragement so that they were actually giving their full effort. And we had a series of 3 images again during each position. All of these measures were normalized to their body weight in kilograms, and we averaged across the 3 trials. We then generated our postural ratios of the anterior to posterior muscles, so rectus abdominis to erector spinae, for both our ultrasound and our strength measures. We also calculated activity ratios, dividing our contracted muscle thickness by our rested muscle thickness. We then looked at paired t-tests to compare means of our strength and our ultrasound-based ratios. Here we can see our rectus abdominis images. On the left, we see our rested image with the purple arrow looking at our superior to inferior fascial border images with our scaling to the right, and then our contracted muscle thickness over on the right side. Once we had them move into trunk flexion, going into that crunch position. You can also see our erector spinae at the L1, L2 transverse process level up to the lumbodorsal fascia. Then on the right side, we can see our contracted image. So you can still see our same landmarks with our purple arrow. So out of our 8 healthy, physically active individuals, they also had no history of low back pain or lower extremity injury. They were about 23 years old, so young, healthy, active. We saw overall our rectus abdominis had a significantly greater thickness change than our erector spinae. And there was no significant difference between our anterior and posterior strength. We saw that with our ultrasound ratio, our postural ratio of RA to ES, that the ultrasound was significantly greater than our strength-based postural ratio, which you can see we had 1.1 to 0.89. So that was mostly driven by our significant finding that we just mentioned from our ultrasound increase from our rectus abdominis earlier on. And here we can see our findings in graph form. So on the far left, you can see our ultrasound activity findings with our activity ratio on the y-axis, with our 1 having a dark line representing where our contracted thickness and our rested thickness would have been exactly the same. So you can see that both of our point estimates for rectus abdominis and erector spinae, they were both above that 1.0 mark, meaning that they were both contracting more so than above that rested position, which is great. That's what we wanted to see. We were eliciting a contraction there and significantly greater on the rectus abdominis contraction, which we would imagine, especially during a crunch position. Handheld dynamometry, we see that, again, there was no significant finding there. And then our postural ratio, again, our ultrasound activity, the significant finding is being driven, the increase, by our significant finding with our rectus abdominis that we saw over on our left figure. So overall, we saw that, again, that rectus abdominis thickness change really drove the overall increase in our postural ratio significance with our ultrasound-based measures. And our healthy, physically active individuals really utilized an anterior dependent activation pattern in their postural control. So this should not be that surprising. However, it's really important to document. We are a forward-facing society. We are driving more strength-wise and activity in the anterior direction. And we're able to utilize more so strength-wise and in a concentric nature from our anterior core muscles as opposed to posteriorly. And further investigation of our injured populations might reveal a dysfunctional variance in this postural ratio. There may be more of a reliance on the erector spinae, or even potentially a unilateral dysfunction, driving that pattern to oppose the findings of this present study that may not be seen quite as clear on either side, and we may see not as much of a willingness to go into that maximal contraction either. So it's important to continue to investigate this. Thank you.